Welcome, everyone. I'm Dr. Carmen Puliafito, and I'm here today with Dr. Dilsher Dhoot of California Retinal Consultants. Dilsher, welcome back to Retina Synthesis.
Carmen, thanks for having me. It's always a pleasure.
So, huge developments in medical retina, macular disease with the approval of Pegcetacoplan. And we'd like to talk today about the latest results on the Pegcetacoplan data set. So Dilsher, you gave a great presentation about this at the Clinical Trial Summit. And why don't you tell our audience what's happening?
Yeah, Carmen, it's a really exciting time. We really had an unmet need in these patients with dry AMD and specifically geographic atrophy. And so I gave an update on Pegcetacoplan at the clinical trials at the summit meeting just last weekend at Park City. And just to give you an overview, this was the second largest trial in geographic atrophy in Oaks and Derby. And there were over 1,200 patients that were randomized to receive Pegcetacoplan monthly, every other month, or sham monthly or every other month. And in fact, over 800 patients received Pegcetacoplan. The 12-month primary endpoint, as you know, was a change in total GA lesion area on fundus autofluorescence, and the study continued through 24 months. And then after 24 months, the patients actually went into GALE, which is a 3-year open label extension trial. And we're going to actually see some results from GALE at the ASRS. Key things about this trial in terms of inclusion-exclusion criteria was that, patients that had subfoveal involvement were allowed in the trial. And in fact, the majority of the patients in this trial, 65% of them, had subfoveal involvement. And also patients that had CNV in the fellow eye were not exclusionary. And that's important because we know that if you have CNV in your fellow eye, there's a higher likelihood of developing CNV in your study eye. And so that was a key inclusion-exclusion criteria to be aware of. Just looking at the top line results, we saw that Pegcetacoplan reduced GA lesion growth at 24 months. Any way you look at it, you could look at the primary analysis, which looked at GA lesion change from baseline, or you can look at the mean rate of change from baseline in a piecewise linear slope analysis. And the results are very similar. There was a 21% and 20% reduction in the monthly group, and then a 17% reduction in the every other month group. And so we saw great results from that. And the most interesting thing to me was the increasing treatment effect over time. It turns out that you actually see, when you break it down by 6-month increments, that the greatest benefit was actually in the last 6-month period, in months 18 to 24, we saw 30% reduction in the monthly group and 24% reduction in growth of the lesion in the every other month group, which was very, very interesting. Finally, one thing, the non-subfoveal patients did very well. These are patients that seem to derive the greatest benefit. And in fact, if you look at non-subfoveal patients as early as 12 months, we saw 23% reduction in the every other month group. And this is sustained through 24 months. And so that's just some top line data that I presented, Carmen.
So there's some evidence of changes in preservation of RPE and photoreceptors. Can you comment a little bit on that data?
Sure, yeah. So, when you look at the fundus autofluorescence, you can see that you're saving, retinal tissue, and you can actually measure the amount of tissue you're saving, right? And so when we think about our patients and we see these GA lesions grow, if you look at the Oaks and Derby, you can similarly see that you're saving tissue. In fact, you're saving about 0.8 millimeters in the millimeters squared in the monthly group and 0.7 millimeters squared in the every other month group. And there's been some important work by Christine Curcio and others, which show that there's about 5,100 to 7,700 RPE cells per millimeter squared. And so if you do the math on this, if you're saving 0.8 millimeters squared, that's up to 6,400 RPE cells that you're saving. And this is greater in those extrafoveal patients. In those patients, you're actually saving up to 1.3 millimeters squared. And so you're actually saving up to 10,000 RPE cells. And we know that there can be 12 to 30 photoreceptors per RPE cell. So the savings in those patients that, in terms of photoreceptors, is even greater in terms of the numbers.
So what about artificial intelligence? Does it have a role in managing geographic atrophy and Pegcetacoplan?
Yeah, absolutely. I think we're just at the tip of the iceberg when it comes to artificial intelligence, specifically. We can see if you do OCT segmentation in these patients, you can actually measure RPE and photoreceptors, right? And so what we find when we measure RPE with AI-based OCT is that you're actually saving very similar. It really validates the autofluorescence results. You're seeing that there's a savings of 22% and 20% in Oaks and 27% and 21% in Derby in the monthly versus the every other month group in terms of RPE loss. And then when you look at photoreceptors on this AI-based OCT segmentation algorithm, you see actually a greater reduction in photoreceptor loss at 24 months. It ranges in the monthly group from 47 to 53% savings of photoreceptors versus 46% in the every other month group. So it's very interesting that the question always comes up. What exactly are we achieving by treating patients with pegcetacoplan? And these post-hoc analyses and in various ways of measuring anatomic improvements are very helpful to kind of understand that we really are saving retinal tissue here, which ultimately, hopefully, is going to translate into visual data, which we also presented at the Clinical Trial Summit.
So how do you evaluate patients with geographic atrophy?
Yeah, in my clinic, I'm generally using both OCT and fundus autofluorescence. So we're looking at these patients kind of in a multimodal fashion. And so I'm usually getting fundus autofluorescence at 6-month increments at baseline and then every 6 months. But these patients, we used to follow them every 6 months. And so we were getting both of these modalities each time. And now I'm generally getting OCT as I'm treating them each time with pegcetacoplan. And then I plan to still get fundus autofluorescence. I think the on-FOS imaging is very good too. But I think for patients, and to measure the lesion, I really like fundus autofluorescence.
So what patients are you selecting for treatment?
I look at when I look at the inclusion-exclusion criteria of this trial, I've let that kind of be my guides, right? So, if a patient could have been enrolled in the Oaks and Derby based on, the simple inclusion-exclusion criteria, I'm considering that drug for these patients. But I think that the patients that seem to be to have the most benefit would be those patients with extrafoveal lesions, right? Because if we can save these patients, I think we'll get more time and more vision from these patients. Those are really the most bang for your buck, so to speak. There are certainly patients that are motivated that have foveal lesions also. They want to preserve anything they can, and so I have some patients like that also. But the extrafoveal patients seem to be the ones, in my opinion, that will benefit the most, at least right now.
What's your treatment interval?
I'm using every other month. I think the safety data really seems to be different, right? And so we saw higher levels of CNV in the monthly group at 24 months. The rate was 12% in the monthly group versus 7% in the every other month group. And so that's one reason. We saw lower inflammation. It was 4% in the monthly group versus 2% in the every other month group. So that's the second reason. And then finally, the NION rate, the ischemic optic neuropathy rate was lower also, 0.2% in the every other month group compared to 1.7% in the monthly group. And so for those reasons, I think that, the every other month group seems to make sense. The efficacy is not that different, so it's incremental decline, but really very similar. And I think the burden also is much lower. It's more palatable to come in every other month versus a monthly dosing in this patient. So I think that every other month makes sense for those reasons: safety, efficacy, and then durability, or really burden.
What kind of diagnostic testing do you do on each visit?
Every visit, patient will get an OCT. Every 6 months, fundus autofluorescence. Those are kind of the main things. And the other thing, Carmen, is really important that these patients have expectations set early on, right? Because I really make a point to emphasize that this drug is not going to this drug is not going to stop growth or reverse growth, but it slows the growth, right? And so patients really have to understand that. Otherwise, they'll be upset if they perceive any kind of growth.
Any tips on the injection technique?
The drug is more viscous, right? The volume is 0.1. I mean, 0.1 is not foreign to us. We've used that before, for triamcinolone, for example, but the drug is very viscous. And so it is helpful to practice drawing the drug up, and the company provides demo kits to do that. And so that's very helpful. Once you've done a few of them, it becomes easier. You have to use a larger bore needle. So they provide a 29 gauge thin wall needle to help inject the medication. And so I think that's very helpful. I generally inject inferiorly, but the rest of the injection is very similar to a typical injection.
What about pressure elevation following injection?
It's interesting. These patients, some of them can have a transient loss of vision right following the injection, but the majority don't seem to have that, and they have hand motion, which implies the nerve is perfused. In the trial, it was less than 1% of patients that had a paracentesis, right? And so, and this includes those patients that had, anti-VEGF provided also on the same day. And so, it's generally, I haven't seen the IOP issue to raise much concern in my patients thus far.
What about bilateral injections? Do you have many patients on that protocol?
Yeah, most definitely. I've got patients that are very motivated, and we're doing, Pegcetacoplan in both eyes, and they seem to be doing quite well. So it hasn't been very different than anti-VEGF in my hands.
Well, Dilsher, this has been a very provocative and informative discussion. What do you think is going to come next?
I think just like we saw with anti-VEGF here in this space, we're going to be looking for more durability, right? I think that we'll see durability plays and potentially other mechanisms of action. I mean, everything is centered around complement here, but I mean, it's exciting to see the pipeline. I think this GA seems to be a fantastic space for potentially gene therapy, and so my hope is that we'll have durable plays there, or potentially other sustained delivery devices.
Great. Thanks you for joining us on Retina Synthesis. We'll see you back soon.
Hey, thanks for having me, Carmen. It's always a pleasure. Thank you.